You're now live, Chair.
Right, thank you. Okay. Okay, hi everybody. Welcome to the meeting.
Morning.
Morning. So we will make a start on the procedural items. So substitutes nominated for this meeting and apologies.
I think we've got apologies from Councillor Clark, Chair, and Councillor Marshall-Catung will be joining us at 11.
Thank you. Any members' interest?
No.
Admission of the public. It is not recommended that the public be excluded from the meeting for the consideration of the items of business on this agenda. Okay, public deputations. I understand we've got 2 this morning. Morning, Jenny.
Morning.
Do you want to start yours first?
Yeah, okay.
Okay.
Thank you. Okay, it's probably going to be more like 3 minutes than 2 because it's really hard to only do 260 words. And before I start, I'd like to ask why it's gone down to 2, because we always used to get 5 minutes. And I'd like a plea to go back to 5 minutes in future. But so I'll start now. Thank you. Okay, so this is on behalf of Calderdale and Kirklees 999 call for the NHS. And it only picks up 1 point because we're so short of time. So the draft Integrated Care Board Constitution and Governance documents are to implement retrospective legislation currently going through Parliament that regularises the cuts and privatisation programme of sustainability and transformation plans and partnerships and their successor integrated care systems. So our big question is, do these documents guard against these twin threats to the provision of a comprehensive universal NHS that is free at the point of use, publicly provided, funded and run, and based on meeting patients' clinical needs in the most appropriate manner? And we have to say, not really. New paragraph 1.12 in the Constitution does not confirm that the Integrated Care Board will arrange for the provision of a comprehensive universal health service free at the point of use for everyone in any place, local authority area, within West Yorkshire and the Craven District Council area, whether normally resident or not. We need a constitution commitment that the Integrated Care Board will arrange for the provision of a comprehensive universal health service for all the residents of West Yorkshire and Craven District Council and those residents elsewhere who need healthcare while temporarily in the area covered by the Integrated Care Board, as well as for residents of West Yorkshire and Craven District Council who fall ill and need healthcare while temporarily in other Integrated Care Board areas. People must be sure of prompt NHS treatment if they need it outside the integrated care system or the place where they normally live. There are already examples elsewhere in England where this has not been the case. So the Constitution must specify that the statutory Integrated Care Board will operate a clear and automatic process of cross-charge, recharge for patients treated by West Yorkshire NHS whose costs as non-residents are not covered in the West Yorkshire Resident Population Integrated Care Board financial allocation. It must do the same thing for West Yorkshire resident patients treated by other integrated care boards, whether this is as a result of patient choice or of falling ill while temporarily out of West Yorkshire. And it must specify that regardless of West Yorkshire patients' place of residence, if they need urgent or emergency care outside their place, which receives the financial allocation for their care, they will receive it without question, wherever they may be within the West Yorkshire Integrated Care System area. So that's it. Thank you.
Okay, thank you for that, Jenny. And I think we've got a second one, have we? Rosemary.
Yeah,
Rosemary, yeah.
Hello, thank you. Rosemary Hedges, on behalf of Calderdale and Kirklees, call 999 for the NHS. I would like to raise some questions about the second draft constitution, which I hope the councillors will seek answers to in this meeting. Number one, why will the member bringing the perspective of providers of community services no longer be restricted to NHS trusts? Does this mean that person could be a VCSE, charity or private provider? We do not agree with this change. 2, paragraph 1.11.1. The Constitution does not seek to introduce a hierarchical model, rather it supports a mutual accountability framework. This is aspirational and disingenuous. In the end, the IC board has to impose financial discipline on all its members. It should be upfront about this, particularly in light of the extraordinary statement in 1.112 that there is no legal connection between the ICB constitution and the separate constitutions of other organisations in the ICS. 3, coming back to the need for the IC board to arrange for the provision of a comprehensive universal health service for all the people in its area, whether permanently or temporarily resident, we are worried and confused by paragraphs 1.114 to 18. These are about so-called integrated neighbourhood services. We are particularly concerned about the emphasis in 1.118 on patients with long-term ailments being expected to self-care at home, and the lack of clarity in related paragraphs about how NHS and social care support for self-care are to be provided. First, we are worried that, as the then Calderdale CCG Chief Officer told a meeting of Calderdale and Kirklees Joint Scrutiny Committee, this care closer to home model represents a shift away from the dependency model of healthcare. We would like to point out that this construction is dangerously close to calls by the Tory government Social Security Secretary, Peter Lilly, 30 years ago, to close down the something for nothing society. A later Green paper reinforced this view of legitimate support needs of disabled people as being welfare dependency. The project, called Deaths by Welfare, has exposed the toxic legacy of this mischaracterization of disabled people as dependents and scroungers, which has led to countless avoidable deaths of disabled welfare claimants amid a culture of neglect and negligence in the Department of Work and Pensions. Researchers at Sheffield Hallam University have built on the work of sociologist Zygmunt Bauman, who described how modern bureaucracies can create psychosocial factors that enable ordinary people to carry out harmful and cruel practices on other people, as has happened in DWP processes. We are therefore worried about the confusion and lack of clarity in paras 1.114, which substitutes local care partnerships for primary care networks. Why the change of name? We know what primary care networks are, but what are local care partnerships? Paragraph 1.115 says that the neighbourhood services provided by local care partnerships sit within each of our 5 places. We find this very confusing. How will neighbourhood services be commissioned and provided by local care partnerships, which sit within each of, how will neighbourhood services be commissioned and provided, falling as they seem to do between local care partnerships and place care partnerships? We know from the work of Calderdale and Kirklees Joint Scrutiny Committee that the care closer to home schemes that are supposed to reduce the need for unplanned, acute and emergency hospital care are unevidenced 7 years after their introduction in our area. We think this whole area of the Constitution needs to be revisited and clarified in order to make clear how care closer to home, stroke hospital at home, stroke integrated neighbourhood services will be commissioned, provided and contract managed. Thank you.
Okay, thank you both very much for bringing these to the meeting. They'll be considered in the subsequent items, but I've seen Ian scribbling away there, so he may be able to answer some of those questions. Okay. Right, next item, minutes of the meeting held on the 30th of November. Can we all approve those as a correct record? Yep, brilliant. So the first business item then. Okay, thank you both very much for bringing these. What happened there?
I think that was your voice and a feedback, Luke, Councillor Greenwood.
Oh, I don't like that. Am I okay now? Yeah. Okay. So we'll move on to the next item, integrated care system governance, and we've got Stephen and Ian here to present these reports. Okay. Thank you.
Morning, everyone. I think I know most people on the call, but for anyone who doesn't know me, I'm Stephen Gregg. I'm the governance lead for the Health and Care Partnership, and I've been working with our partners across the integrated care system on the co-production of our governance arrangements. The report you've got today provides an update on the ICB draft constitution and the arrangements which underpin it. I won't go through the paper in detail. I'll try and summarise some of the key issues and then give plenty of time for comments and questions. I think probably the most important thing to set out is that since we last presented to the JHOSC back in November, as you'll be aware, the implementation of the Health and Care Act has been delayed by 3 months to 1st of July. So we're still awaiting some key guidance, for example, around the appointment of partner members to the ICB board and guidance around management of conflicts of interest. We're expecting a further model, national model constitution to be issued on the 31st of March. So we'll need to make more changes to our constitution to reflect the change in the national model. So it is still very much a work in progress. And so in view of that, the comments from yourselves today, will be particularly helpful in terms of refining the draft as we get towards finalising it. But although some of the detail may change, we're very clear that our arrangements, we're aiming to be inclusive, we're aiming to be transparent, and we're seeking to enable most decisions to be made about funding and care to be taken in place close to local communities most affected by those decisions. So when we came to you in November, we were part way through a stakeholder involvement process, which ran from November to January. And we had some really helpful feedback as part of that process from partners, members of the public, overview and scrutiny committees, both at West Yorkshire and place level. And we've used that to refine both the constitution and the supporting arrangements that will underpin it. There's a summary of the feedback we got from the involvement process at Annex 1, and the amended draft constitution is at Annex 2. So we've made a number of detailed drafting changes in response to the consultation and a number of wider changes. Probably just worth highlighting 2 or 3 in relation to some of the key issues that were raised during the consultation. So we've clarified our objectives in terms of committing to provide comprehensive health service, reduce health inequalities, and improve health and well-being. And it's probably worth pointing out that paragraph 145A of the Constitution commits the ICB to promoting the wider NHS Constitution. So that picks up that commitment to a comprehensive service available to all based on clinical need, not on individuals' ability to pay. So that's actually, that's baked into the Constitution in terms of what the ICB is signed up to delivering. We've made a number of changes to board composition in response to the involvement. All providers are included on the board, including primary and community care providers. We've strengthened independent challenge through the appointment of an additional independent non-executive member. We've recognised the key importance of workforce challenges, workforce investment, safe staffing by having Director of People as a board level appointment on the board. You'll note there are no private healthcare providers on the board, and we're expecting that the final version of that will include some wording around that, but we've been very clear from the start that we have no plans to have private healthcare providers on either our board or the committees that support the board in its functions. We set out clearly the role of board partner members as representing their wider sector, not acting as delegates. And we built in formal and rigorous annual evaluation of both the board and the wider governance arrangements. Some of the wider comments we had as part of the involvement were around patient and public engagement in relation specific to involvement in decision-making committees. And we're very clear that all decision-making, the board and all decision-making committees of the ICB will be held in public unless there are reasons of confidentiality why that wouldn't happen. And we're also developing proposals for a citizens panel. And as part of that, we've recognised the key importance of involving elected members in those wider citizen engagement arrangements. The feedback from involvement, I think a broader message highlighted the need for our governance handbook to, if you like, tell the wider story of how we operate in West Yorkshire and not simply be a scheme of reservation and delegation and terms of reference. So we want to make sure that that governance handbook covers the wider partnership collaborative arrangements that inform ICB decision making. For example, the absolutely key role of health and wellbeing boards and our partnership board in setting strategy, the role of our provider collaboratives in decision making and partnership working at place and system level. And I think my colleague Keir Shelliker on the subsequent item will be telling you a bit more about that, but we want to make sure that that's reflected in our governance handbook. And we recognise the need to be absolutely clear in that governance handbook about the delegation arrangements and funding flows and how they will work in practice. So we're developing a set of case studies that will cover decision making across both places and ICS footprints, and really kind of set out in real terms how we will make decisions, as opposed to the kind of fairly dry sort scheme of reservation and delegation. But you have got Annex 4, that outlined draft scheme of reservation delegation that sets out in very broad terms how we plan to delegate, particularly to place level committees. In terms of recruitment, we've recently announced a number of executive appointments to the ICB board, and recruitment to the independent non-executive member roles is currently in progress. As I said earlier, we're still awaiting some national guidance on the nomination process for some of our partner members, for example, NHS Trust, the primary care member, and we can't start those appointments until those partner member regulations become law. We now understand that that not be until May. So there are some inbuilt delays to putting in place some arrangements that we just have to wait for the legislation to progress before we can agree the details. Mentioned earlier, the governance handbook, absolutely central to that model is delegation to place. Each of our places is establishing a committee to take decisions about ICB functions and resources in place. And we've started the recruitment process for independent roles on those committees. Alongside place-based committees, we're also establishing some West Yorkshire level committees to support the board around some of its key functions, and the draft proposal around those committees is at para 15 of the report. So we're proposing a committee around finance, performance and investment, committee that focuses strongly on system quality, one that focuses on transformation, so those clinical thresholds, service specifications and pathways where we absolutely want to be consistent right across West Yorkshire. We picked up feedback around the importance of the workforce agenda. We plan to establish a people committee that has a strong focus on delivering our system people plan and priorities, and workforce investment committees. And then clearly we need to have our two statutory committees around audit and remuneration and nomination. And we're currently working through the process of making sure that all those committees feed into our scheme of reservation and delegation. We're avoiding any duplication and overlap between the two. But that's quite a lengthy process to make sure we've got the terms of reference exactly right. In addition to kind of formal ICB governance, wider ICS governance is equally important. You'll know the role of the Integrated Care Partnership, which is currently our partnership board. Technically, from the 1st of July, that will be a joint committee of the ICB and the local authorities in West Yorkshire. So we'll not be able to formally establish it until the ICB has established itself in July. But we're liaising with local authority governance colleagues over the arrangements for formally establishing that ICP. Until that time, we propose that the partnership board, as it's been operating for the last 3 years, continues to meet in its current form. And that formal ICB committee structure is only one part of our partnership decision-making infrastructure. We carry on with our existing collaborative forums, bringing together, for example, clinical and professional colleagues and finance colleagues across the partnership. The delay in the Health and Care Act, we think, provides an opportunity for us to get things right rather than do things quickly. It also provides us an opportunity to test our arrangements during a period of shadow operation starting next month and running through to June. So, for example, we've established already a shadow remuneration and nomination committee comprised of trust, non-executive directors and CCG lay members to make recommendations to our remuneration committee once that is statutorily established in July. And as further recruitment to ICB board roles progresses, including those independent non-executive member roles, we'll be in position later next month to establish our shadow board and some of the committees. We're absolutely clear that our new governance arrangements, we're trying to make sure that they represent evolution, not revolution, build on what we see as successful partnership working over the last 3 or 4 years. But we know we won't get things right first time, so we've built in some clear review periods into the first year of operation of the new arrangements. So in terms of refreshed timeline, we're planning to present a further draft of our draft constitution to our shadow board next month. Mention that period of shadow operation, April to June, with a final draft constitution going to our partnership board meeting in public on the 7th of June, prior to the establishment of the ICB in July. So members are asked to comment on the messages from stakeholder involvement, the amended draft constitution and supporting documents. To note very much that the constitution remains in draft, still subject to legislation and regulations, and that work is ongoing to further develop our governance handbook. And we'd suggest we possibly come back to the committee in June with that final draft to give you that opportunity when we've got some of the detail around terms of reference finalised to provide final comments on that. So that was all I was planning to say. I don't know, Ian, you wanted to add anything, but open it up to questions and comments from the committee.
Yeah, thanks, Stephen. If I could just say a couple of quick things. That's really clear and really comprehensive. I guess the first thing to say is that we've been really pleased with the response and the engagement that we've had in this document since we published it in November. You'll remember there was a national requirement to engage in this for 2 weeks. We engaged for, I think it was about 9 or 10 weeks. And hopefully you'll see in Annex A, we've got quite a clear statement of the feedback that we've had and how we've responded to that. And our views that's genuinely strengthened the document. So that's been really helpful, including the comments that we received from this committee. The second thing to say is that obviously the timescales, the change in the national timescales around implementation have had a sort of material impact on where we've got to by this point in time. Clearly, if we'd been going to these arrangements from April the 1st, we'd have had the full handbook now. We're not at that point yet, but we'd be keen to come back and have a further conversation when we've got a good draft of that handbook. Although I think as Stephen's described, you can see how that's going to be shaping up. That's all I want to say, Councillor Greenwood. Thank you.
Yeah, thank you both for that. It was very comprehensive, actually. And I'm glad to see that you're not rushing it and getting it right. And I'm really pleased that you are taking all our comments and others into consideration. You have made amendments accordingly, we're grateful for that. Okay, so we've got Councillor Latty with his hand up first.
Thank you, Madam Chairman. Yes, just a point. Going back to the very beginning of your presentation, the board itself and the size of it. And I just express a bit of concern at the sheer size of the board, the numbers. Over many years' experience of committees, the bigger they are, the more they tend to strangle themselves with their own importance, shall we say. And it does slightly bother me that from the minimum national requirement of 10, we go up to 24, that I just wonder whether that is an absolutely essential. In the sense, contrary to myself here, I would question, you did say that there was no intention to have any representation from the private sector. I just wonder, at some point, does this represent a closing of mind to the existence of the private sector and the fact that at some point the private sector can be useful to the care board in fulfilling its aims, shall we say? It's a question really of capacity, and I just wonder whether it's a cutting off the nose to spite the face sort of thing. I'll leave it at that. Thank you.
Did you want us to respond or wait for comments, Councillor Greenwood, and wrap those up in one? Happy
If
to...
you can respond to each one as we go along, I think a bit.
Okay, yeah. Thank you, Councillor Latty. Really good points there. And we tussled with that issue of inclusiveness and effectiveness of the board over quite a lengthy period, because we are conscious that best practice would give you a smaller board than 24. But one of our commitments is to retain that kind of inclusiveness, the inclusive nature of the partnership that we've built up over the last 3 or 4 years. So we felt that certainly initially we needed to ensure we did have that inclusiveness, and that all key voices were represented on the board, recognising that does present challenges in terms of effectiveness. So as I say, we built in some review periods to make sure we absolutely check back on ourselves and say, yeah, we've set ourselves quite a challenge with a larger board than best practice might suggest, and we need to be absolutely certain that is operating in the right way. In relation to private sector involvement, yes, we're clear that that there won't be private sector involvement on our board, though we do also recognise that we do need to engage with the private sector in a whole range of other ways. So we recognise that we need to engage with the private sector. We've been clear that in terms of formal decision making, that it wouldn't be appropriate for that representation on the board.
Okay, thank you. Councillor Hutchinson.
Thank you, Chair. I too welcome some of the changes that have been put in place in the latest version of the Constitution, particularly the involvement of a people committee, and a commitment to promote comprehensive healthcare as one of the objectives of the board. But I'm not quite sure why it's promote rather than arrange the provision for comprehensive healthcare, which, at some point someone has to arrange the provision, and as the ICB is the only statutory element to this, it would seem sensible that their responsibility was to arrange the provision. But if after this meeting, if I was to go hop on a train to York and then get run over by a bus in York, I know that all the emergency care that I needed would be provided without question in York, and that's been the case ever since 1946. But I can't see anything in this document that defines any duty on the Integrated Care Board to ensure that somebody from West Yorkshire who visits York and needs access to urgent health care, if that need should arise, will be able to get it. Similarly, the hordes of students that come and study in Leeds, if they were to fall ill in Leeds and weren't originally from that area, what is there in this constitution that says that they can expect to have their care needs met while in Leeds? I mean, I can foresee the need for health insurance if I venture beyond the boundaries of West Yorkshire, and particularly if I were, heaven forbid, to go as far as Scotland or Northern Ireland. So what arrangements are there going to be in place for that? Is it possible to change paragraph 1.1.2 to say the ICB will arrange for the provision of a comprehensive universal health service for all the residents of West Yorkshire and Craven District Council and those resident elsewhere who need healthcare while temporarily in the area covered by the Integrated Care Board, as well as for residents of West Yorkshire and Craven District Council who fall ill and need healthcare while temporarily in other IC board areas. You may think that, you know, that this goes without saying, but a couple of amendments when the bill was in its passage through the House of Lords were rejected by the government because they said it would not be reasonable to expect providers to provide services regardless of whether they were funded by an ICB to do so. And it's important that ICBs should be able to make decisions about with whom they contract and where they prioritise their resource. And that was Lord Kamal who said that in rejecting those amendments, which does make me think that they're favouring reducing the risk on providers while increasing the risk to the general public. So I'd just welcome your thoughts on whether the next version of the Constitution may include a change in that to make that clear.
Do you want me to come in there, Councillor Greenwood?
Yes, please.
I mean, what you've said sounds perfectly reasonable to me, Councillor Hutchinson. I think the difference between promote versus arrange the provision for, I think that's probably language, and I think if that's clearer, we can look at that. In terms of the point around responsibility for folk receiving healthcare elsewhere in England, and the responsibility for West Yorkshire services providing for people who are within West Yorkshire and fall ill in West Yorkshire, I think we were in a place of that goes without saying, but if it's helpful to be explicit about it, we can look at that as well. So I think what you're saying sounds absolutely reasonable. We'll check it back against the Constitution, but I'm pretty sure we'll be able to make those amends.
That would be very welcome. Is it possible for me to have another question, Chair?
Yes, it is. I think Stephen, you've got your hand up. Did you want to also respond to that first question?
Yeah, yes. If I get yes, I think a number of these issues are. If you look at our commitment to deliver against the NHS Constitution, then I think a number of these points are should be satisfied by that. But if there's value in being more explicit about that, rather than referring to referring to delivery against the wider NHS Constitution, yes, we can certainly look at doing that just to make sure it is there within the Constitution, within the links within the Constitution. But if there's value in being more explicit, we can certainly look at doing that. Yeah.
Well, presumably the arrangements would be need to be put in place to reimburse between different integrated care boards for such care, and including across the other three nations of the UK. My other question was about what is actually happening at place level, because I'm quite confused about it. You know, paragraph 1.1.14 stresses that collaboration begins at neighbourhood level, and it's been suggested that the ICB structure or the ICS structure is built up from neighbourhood level. So I'd really like to understand better the respective roles in designing, commissioning and ensuring the quality of services provided by primary care networks, which are already set up and described as the building blocks of place-based partnerships in Annex 4. Local care partnerships, which are a new one to me, I haven't seen those mentioned before. Place-based care partnerships, place-based integrated care board committees, integrated care board place subcommittees, health and wellbeing boards. It seems that there's the potential for a huge amount of confusion as to who does what, a lot of potentially redundant jobs, and considerable overlap. So how are neighbourhood services going to be commissioned and provided in this? The functions map that's in Annex 5 doesn't make things very much clearer for me. It looks like a whole system, that Annex 5 suggests that the whole system is being driven by the health and wellbeing boards, and that the integrated care board is simply a facilitator. But one of the key decisions is the allocation of budgets. If you don't have a budget, then no strategy can work. So does this diagram in Annex 5 actually show the right flows? It also seems to underplay the role of provider collaboratives like MHL, the Mental Health and Learning Disability and Autism Collaborative, about which we also have a paper today, because they tell us in their presentation that they're taking responsibility for commissioning specialised services, but with accountability and direction remaining with the respective executive director of commissioning in the lead provider trust. So, you know, the collaboratives are doing commissioning as well as being providers. How's the responsibility split between them? So I'm just rather confused about this, and I don't think Annex 5 actually reduces my confusion.
Okay, Stephen, you're going to speak to that, or Ian?
Stephen, do you want to go in first and I'll come in after? Do you do it that way?
Yeah, if Annex 5 you think makes things more complicated and less complicated, then we need to look at that. What that Annex 5 is intended to do is set out very simply, not to represent all the engagement with different partnership levels, partnership groups at different levels, but to be very clear that strategy is set by health and wellbeing boards and the partnership board. Delivery is through the ICB board and through place-based committees, and the funding flow, you talked about funding flow. The funding flow is to place-based committees to make those decisions at place level around the commissioning of services, whether that's community services or acute services. So that place-based committee is right at the centre of ICB decision making, and there's a range of groups that will feed into that. But that is, in terms of a formal delegation and decision-making process, that is the key decision-making process in each of the places. But if you feel that diagram could be clearer, we can certainly look at adapting that. But we've tried to make it as simple as possible to give that clear picture between setting strategy, health and wellbeing boards, partnership board, delivery in place, with provider collaboratives and other collaborative groups within the partnership informing that, but not being part of the formal decision-making process.
So these local care partnerships, they don't seem to feature on that diagram. And as I say, they're a new term as far as I can tell. What's happened to primary care networks?
I have to confess, I believe that is a drafting error in the latest version of the Constitution. We had some feedback that around reference to primary care networks might be more helpful, because in some parts of West Yorkshire, local care partnerships is an accepted term. I think primary care networks is the accepted term that everyone understands. So I think we need to revert to that in the final version of that. So that is simply a drafting error.
Okay, that would reduce one area.
Yeah.
Thanks.
Okay, thank you. I've got Councillor Smage next.
Thank you. Can I just, before I go to my main question, can I just clarify, please, that healthcare will be freely available to anyone who needs healthcare wherever they are? Can you just give me a quick yes or no? Because I just think it needs a clarity here.
Yes.
Thank you. Thank you. So my questions are on 1.1.18. You've changed this slightly, and it took me a little while. It took me a few readings to get the changes, and it's about the long-term conditions. So what you're saying is, I think what you're saying is that various groups of health provision and social care provision will be available for people who have long-term health conditions, but that's not necessarily that they need all of those at any one time. That is what's going to be available if they need them. Is that right? Because long-term health conditions, you can self-care at home perfectly fine by just going to your doctors, dependent on how severe your long-term health conditions are, or you may need a whole raft of services, including hospital services, to help you manage those long-term conditions. So can you just clarify, please, what that wording is? Because I think it's got a little bit clumsy there, and I just would like some clarity on that. On your governance handbook, it's a bit deja vu-ish, in that we were told at the last meeting that the governance handbook would be coming out and we'd be able to scrutinise that, and we're still not seeing it. And I wonder if there's actually some timescales to that, so we can actually do some scrutiny of that governance handbook, because there seems to be an awful lot in it that's not in the Constitution that I think would help with the scrutiny process. And at your end drawing, I think, and let me just see, there we go, Annex 6. This is supposed to be the governance and accountability. Well, I find this a little bit confusing. And the collaborative forums, I'd like to understand what decision-making process are involved in these collaborative forums, please, because we don't see any, they're not open for scrutiny at least one of the collaborative forums that's been in place for some time. And therefore it's very difficult to see how a decision goes through all of the processes. And I think that's important for us to be able to see how that decision process works across all of these processes in order to provide full scrutiny. Thank you.
Okay. Who's going to respond to that?
Do you want me to have a crack at that one, Councillor Greenwood? Yeah. So that we can have a look at the words under 1.1a, Councillor Smidge. Thank you. I think the point is if you've got a long-term condition, you know, we want to be able to support you to look after yourself, to be looked after in your own home. We recognise that you will need to have a relationship with GP and community providers, and we recognise that at times you will need hospital services as well. And that's the kind of the point that we're trying to make, which is that we know that all of those things will be necessary at one point in time, but the idea is that we want to support individuals with their families to stay as well as possible at home, and we can tidy that up if we need to. On the governance handbook, we're absolutely committed to bringing that back here. As Stephen mentioned at the top, the timescales nationally have slipped. A lot of the guidance that we're getting from NHS England has consequently slipped. I think we've made good progress in the sort of the bones of the governance handbook, which Stephen's taken us through today, but we're absolutely committed to bringing back the handbook so that it can be scrutinised and considered here before it's finalised. The point around collaborative forums, so the purpose of these collaborative forums, and Keir will talk a little bit more about the mental health work later on, is that you get partners from the same sector, so mental health trusts, acute trusts, you know, coming together and working together on issues that are important and relevant to them. part of the design of the ICB board is that the partner members will be drawn from each of those collaborative forums so that they have a voice and a role on the ICB to represent that sector. At the minute, those forums aren't decision making, they don't have any formal decision making powers. It's more about ensuring that there's a sector view to feed into those decision making arrangements, which is why they don't currently meet in public.
Could I just come back just quickly? And Annex 5 for the collaborative forums, they look as if they feed into all of the decision making process, that they are part of the decision map. And therefore, I think it would be good for us to see how that decision process from start to finish across all those areas are working. I really do. And the governance handbook, I think we need to look at how we can see that in early form, not just when it's more or less finished, actually have something where we can actually look at it in an early form. Thank you.
Yeah.
Okay, thank you for that. I've got Councillor Swift next.
Right, Kevin Swift from Wakefield. And I'm afraid my kind of requirement for clarification has expanded rather than contracted since I first put my question, as I've listened to the questions that we've just had. So if I can just get the quickies out of the way before my main point, just really emphasising Colin's question about the reference in 1.1.2 to residents. And I think I can understand the people who brought the deputation being concerned about it. I understand perfectly well the assurances that we've been given that, of course, you know, you know that we intend to and so forth. The difficulty is in that particular little paragraph that the term residence is actually a very precise term, so that on the face of it, there isn't any need for clarification. On the face of it, it's absolutely explicit that the obligation is there to provide for residents. So there very definitely is a need for a change in wording and not simply an understanding that we all really know what we intend, don't we? Moving on a little, on this local care partnerships, as I read it in 1.114, certainly in Wakefield terms, there is a quite clear change implied. I'm not saying it's a bad change, because the primary care networks at the moment don't include social care. The primary care networks is set mainly the GP surgery groups. Now, so the change from primary care network to local care partnership, the beneficial as it might be, is actually different in the sense that it involves people like the GPs, and it quite clearly involves social services, adult care, that kind of thing as well, which is really something different. So whether we're talking about the local care partnerships being something new that operates alongside the primary care networks, or whether it's a change, a quite fundamental change in what the primary care networks are at the moment to how they are in the future, I think there is a very definite need for clarification on that one. My main and original point related to the degree of autonomy or otherwise of the place committees in terms of the very, very important decision making that came. It's on agenda pages 1067 in Annex 4, and it's the distinction between which important decisions are made at West Yorkshire level and those which are fully delegated within their budgets, which are fully delegated to the place committees. Now, it refers us to something that may well be somewhere in these pages that I've missed, but it refers us to the 3 tests, which are it seems, to be the criteria as to that which gets dealt with at West Yorkshire. It's kind of placing of contracts, quite a number of quite important decisions, and those which are actually delegated to the place committees. Thanks, Chair.
Thank you. Ian, are you responding to that one?
Yes, thanks, Councillor Greenwood. So I think the point about being precise on the language around residents and the commitment to provide a comprehensive service has been well made. And I think I didn't scribble it all down, but Councillor Hutchinson came up with a form of words there as we were talking. So we might use that as our starting point. So I think that point's well made. I think on the local care partnerships PCN thing, I do think it's a bit of semantics. I think different places have got a different definition of what a primary care network is. Some places have quite a narrow definition, which is that they're groups of general practices working together to be more resilient across a bigger scale. Other people have taken a wider definition, which is that they include things like social care, community services, in some cases voluntary community services. And I think that's why they moved away from the primary care network language, because it's a broader thing. It's a local care partnership. I think the intention is that we have these kind of integrated partnerships of general practice, community services, social care, etc., providing integrated services to populations of 30 to 50,000, and that's the intention. I think we've muddied things with the language, which we will tidy up. The three tests are the sort of the tests that we've had, from the start of the ICS, and I think they are written down in there somewhere, but if not, we can add them in. So the first one is is it a scale issue? So is it an issue like hyperacute stroke or cancer services, where you need to work together on a bigger footprint to achieve critical mass to get the very best safety and outcomes for people? Is it an issue where there's value in working together to share good practice, because one area is doing something really good and other areas there's an opportunity to improve? And the third test is it a wicked issue? So is there some really complex, difficult challenges that we're all facing collectively where it would make more sense to look at together? And workforce is probably a good example of that at the current point in time. So those are the three tests, and we can make sure that we're explicitly referencing the point in the document where we define the three tests.
Okay, thank you. So I've got Councillor Ramsey next, then Councillor Smage, and then Councillor Rhodes. I don't think I've missed anybody. No. Oh, sorry, Stephen. Do you want to respond to that as well?
Sorry, just quickly, just in relation to Ian's last point, those three tests are set out in the introduction at 115, I think. Let me just check. 115 sets out our three tests for working at West Yorkshire level.
Shall I go, Chair?
Thanks for pointing that out. Yes, please.
Thank you very much. Thank you for. I'll just make a plea not to lose the diagrams in Annex 5 and Annex 6, because I do agree that there perhaps needs to be some more clarity around where there may be gaps or overlap. For instance, at the place-based, the Health and Wellbeing Board and the Integrated Care Board, how are they going to work together? So I'm sure there needs to be some description around them, but a diagram is really helpful to me to understand. Alongside them, it may be really good to have some scenarios about where decisions are actually made and how they are fed into. So some simple scenarios about normal service delivery across the patch. My bit was to just go back to Colin's. Really pleased to see the people management taking that role, and I suppose that started me to think around, because people management and all the workforce issues will no doubt figure very greatly on the risk register around recruitment, vacancies, retention, terms and conditions, etc. So I would be particularly interested to understand whether or not we've got a draft risk register being built up at the moment, and when that risk register would be available
for us to review, because clearly there are things that we know about that are huge risks, and obviously want to hit the ground running. I'm sure they're just a continuation of where we are, but we need to see that whole picture.
Stephen, you got your hand up?
Yes, if I may. That's a really good point around those scenarios, and that was one of the main bits of feedback we got from the involvement was, yes, you've got your functions and decision map, you've got a scheme of delegation. What does it look like in practice? So absolutely, that part of that governance handbook, we just want at various levels some practical examples of this is how a decision will be made in these circumstances. We can't cover every potential way a decision would be made, but we absolutely recognise that we need to have those kind of real life case studies just to bring it to life, see how it would actually work in practice. In relation to the risk register and key workforce risks, we're going through a process at the moment with each of the risks on our CCG risk registers. But we're taking a bottom-up and a top-down approach to look at where the risks currently sit, both at CCG level and at system level, to make sure that in that transition towards July, we've got a very clear picture of risk at all levels of the system. So that is very much a piece of work that is ongoing at the moment.
Thank you. Councillor Smidge.
Yeah, just really quick, because I think Councillor Rhodes has been waiting a while. When you're talking about local hospitals, if you need hospital care, mean going to your local hospital. With your wording, can you just please remember that for Calderdale, Kirklees and Wakefield, it is not necessarily going to your local hospital, it is going to a hospital. So, I'm mystery shopping mid Yorkshire at this moment in time, and that is a mix of Pinderfields and Dewsbury. Do you know what I mean? And only one of those would be classed as a local hospital to people in Kirklees and to people in Wakefield, and similarly for Calderdale and Huddersfield. So it's what expectations are you setting in the wordings? It will usually mean going to your local hospital. It's just something for you to think about. Okay. All right. Thank you.
Councillor Rhodes.
Thank you, Chair. It's been rewarding to be last, if that's the case. I've listened patiently to the comments, the questions and the answers. And the first thing that came across my mind was, is everybody forgetting that we are a national health service? When the question comes about of who can be treated where and how can it be dealt with, we are dealing with a national health service. And splitting it up into partnerships should not negate the responsibility of the 1946 resolution of the National Health Service. That's the first comment. The second is that I totally support all the concerns expressed and the questions by my colleagues previously. I had a list of them down, and I'm not going to go through them again because they have been mentioned and they're very, very relevant. But I will say this, it's so disappointing and concerning to know that we have had this ICB board in shadow for about 5 years, to my knowledge. And Councillor Smidge and myself can go back to many, many meetings where we asked several questions about the future of when it was implemented, including the Constitution, including governance arrangements, including how the partnerships would work, including how they would benefit the people in their own areas, which the name place seems a little bit of an enigma to a lot of people, and it certainly does to me. And I've been around in this health service since, oh my goodness me, the early 70s, when I worked voluntary, first of all, in a mental hospital. I've seen that many changes, and official and unofficial, that I have to say the circle has gone round and round and round, where I don't think anybody knows where it's spinning at the moment. the issues that have been brought forward by our delegates' deputation this morning do really reflect the concerns that have been expressed here and that I support. I really do. And I've listened intently. And I have to ask a few questions. What would have happened if there hadn't been the House of Lords intervention that said, go away, you need to look at something else? Because this shadow board would have been in a position, I had thought, or we had thought, after 5 years, to actually start the ICB attention at the previous prescribed date. And here we are now, again, listening to new revelations about local care partnerships, about the position of joint committees of the ICB and local authorities. And they are all such a structure that seems to be put in place that is yet, I believe, and looks like, intent to confuse rather than commit. Why, oh why, is the Scrutiny Committee having to make comment about such things as, and Ian, you just mentioned it, the intention is? That should not be an intention. It should be a policy decision in a document which should say, we will. We will. What's happened to all the years that you've been there looking to this future of the NHS? That's my first lead-in comment, and do forgive me. I think we're all very, very busy people, and I don't appreciate sitting here again listening to an organisation who seems not to be able to look at itself in terms of deliverance. And we have to actually consider that this deliverance is going to make things better for our people. I'm going to go back, and here we go again. Liz and I can go back a long time. And we're talking about the collaboratives, and I totally concur with what's been said about them. Another layer. It's going to be 4 NHS trusts, and the operation is going to be formal committees in common of the trust boards to meet every quarter. 2 questions. Can you tell me what the committees in common is meant to be and why it's every quarter? Because that was the initial intention of the previous commitments of how the board was going to meet. But underneath that layer, going back in my memory and Liz's as well, there was an operational organisation called SOGA. Where is that? Is that still there? Are there still the decision-making body as there have been and were intent on that original document? And are they still the operational decision-making body in between the trust's quarterly meetings? First question. Second question, twice yearly non-exec and governor event. Please explain what that's about. Because surely these bodies or people are going to be part of the overall role and implementation, and in part, I would say again, of the message given of what is happening within the board or the outcomes. There's nothing here about outcomes. The third point says, informal mutual aid, in brackets, and operational support via chief operating officers and regular discussions with other execs. Now, if we're going to look at a process, a policy and decision-making that can be monitored, evidence-based, and indeed the challenged, I would say, what does that mean? What does that mean? And lastly, I mean, I could go on, but I'm not, because most of the points have been said. And lastly, I have to say, Stephen mentioned about the consultation that took place, and Ian commented on the numbers. I did say the last time when we discussed this business How was it going to be? How was the consultation going to be done? How was it going to be delivered? Where was it going to be delivered? And I always recollect that I always say, for those people who aren't IT literate, how are they going to be engaged? That's a big question, because they're the very same people who will want to actually be enabled to get services that they need. So those are points here that I want in terms of the decision making, how it's going to be managed, where's SOGA, what's meant by mutual aid. There are lots of words here in this document that I think are meant. I was thinking about Confucius at first, and then I thought, no, it's confusion. I got the word right, confusion. Confused to deceive. And some of the public, I'm sure, will not have understood one word of the gobbledygook of a presentation that is leaving so much to be answered. And I'm sorry, that's my opinion. It's personal, I know. I've seen that many of them around. I just think it's time we spoke in the people's language to let them know what's happening. Thank you, Chair.
Thank you, Councillor Rhodes. Who's coming in on that, Ian or oh, Stephen? Sorry, you got your hand up. Oh, Keir, I'm sorry as well. Did you want to come in on that as well?
I'm happy to let Stephen go because I'm conscious that there are bits in there that are certainly for my bit of the will, but I'll let Stephen go first.
Okay.
Thank you, Councillor Rhodes. Yeah, I'll pick, because I think 2 or 3 of the points are more in relation to Keir's presentation than the governance piece. In terms of clarity around decision making, we're absolutely clear that functions and decisions map sets out or seeks to set out that formal decision making is with the ICB board and committees of the ICB. It's not with the provider collaboratives, it's not with the collaborative forums, that all work together to inform those decisions. But we try to be clear that where it comes to making decisions about the use of resources, those are made in public at formal decision-making committees, whether that's in place or at ICB level. And I think probably the case studies might just help to unpack a bit more of that in terms of being clear, because we can have a diagram, we can have a scheme of reservation and delegation, but there's still that question, okay, how does it actually look in practice? So we will seek to make sure that those case studies underpin that functions and decisions map with that clarity about how we want to take decisions. I think in relation to the delay, I mean, we've been working as a partnership for the last 4 or 5 years, but we haven't been working as a shadow statutory partnership. We've been working as a voluntary partnership, bringing together statutory providers. And so all of the governance arrangements that we need to put in place to go to a statutory strategy basis have been needed to be developed from scratch. So I don't think it's not a question of, well, we've been working in a partnership way for the last 4 or 5 years, but we haven't been a statutory organisation. So we have needed to make sure that we develop some kind of harder edge governance to support that. I think probably the other points were more around Keir's presentation.
Thanks, Stephen. Shall I just quickly jump in there, Councillor Greenwood, to say, so I'm more than happy to pick it up now or to pick it up as part of the presentation in a minute, but essentially those comments that Councillor Rhodes made about the committees in common element, the bit about the NED Governor event and the kind of
Keir,
concept.
Keir, can I just interrupt? Keir, can I just interrupt?
Yeah, of course.
Sorry, Stephen. That wasn't an answer good enough. Liz, Councillor Smage and myself, we are well aware what the situation is with this board and how it was set up, about the partnership, etc. So I think the answer is not good enough, to be honest with you. For those of us that have been around and have watched what should have happened and how it's been happening and comments that have been made, we've made a lot of comments around these. So I don't want anybody to flower over me. I'm not in the mood for that today. What I am in the mood for is really good answers to the situation. You didn't mention SOGA. What's happened to that? Is that still there as a decision-making body? Because that's the way they've been working. You didn't mention the difference between the decision-making and who would be monitoring between every quarter and the outcomes. That's an important part about it. Who will be doing that in between board meetings? What if there's a situation where the outcome is not a valid quality outcome? Who deals with it? Who are the people responsible for that? It says, and I quote, mutual aid and operational support via chief operation officers and regular discussions with other executives. That cuts across the scene for everybody. Who are they? What does mutual aid mean?
Shall I just come in there, Stephen? Because I think that bit is specific to the work of the terminology we're using there is specific to the work of the Mental Health Learning Disability and Autism Collaborative. So I'm happy to explain that as part of our presentation.
So we've got two agenda items here, and we've jumped into the second one. So I would suggest that we pick up those questions about the coups and the mutual aid points as part of Kay's item, because that's the next item on the agenda. I mean, all I'll say in addition to what Stephen said is that if the legislation had passed in time, we would have been in a position to have the board up and running in April, because we would have had the legislation, we would have had the guidance. We're still receiving guidance from NHS England now, Councillor Rhodes. We can't go ahead with the partnership member appointment process until we've received that guidance, so we can't finalise our arrangements until we understand what's in the legislation and what associated guidance is coming out from NHS England. But we are, I think our arrangements are progressing well. They would have been in place for April had not been the delay, and they'll certainly be in place by July. And as Stephen said, it's a different thing setting up a board that is a statutory board that needs to be done in accordance with the legislation to what we've been doing over the past 5 or 6 years, and that's just a fact.
Thank you, Ian, for that. And I know it's going into the next item, but I want an answer to the question, please, on what was the previous structure. The previous structure had the 4 quarterly meetings of the ICB board, and underneath that it had SOGA, who were the decision making in the interim period between board meetings. My question is, what has happened to those? Because irrespective of what services looked at, that was the structure. Where are they now?
So there was a... sorry, Stephen, go on.
Can I come back on that one, Councillor Rhodes? Yes, we under our collaborative partnership arrangements, we had the System Oversight and Assurance Group, SOAG, which had a kind of general oversight, but it wasn't as part of a statutory arrangement. So as part of the statutory arrangements, the type of oversight that I think you're asking about will be done by what we're establishing 2 committees, a Finance, Investment and Performance Committee and a Quality Committee. They will both meet in public. They will oversee risks, performance issues, whether it's in relation to finance or quality, and they will report into the ICB board. So SOAG was some System Oversight and Assurance Group was part of our old style collaborative working. Moving to a statutory organisation, we're having formal decision-making committees that will meet in public that will inform the board.
Thank you, Stephen. Finally got an answer. Thank you very much. Over to you now, Keir.
Kay, do you want to come in now, or are you going to respond in the next item?
It's probably easy because I know we've got a couple of hands up. I'll make sure I pick it up in the next item, and then Councillor Rhodes, if I'm not answering your question, then please do come back then.
She will. She'll remind you.
I will.
Okay, Councillor Hutchinson.
Thank you, Chair. I mean, obviously, the most important people in this consideration of the integrated care system are the current and future patients, but the second most important people are the staff, the professionals that actually deliver the service. In Annex 4, ICB 6 refers to developing and supporting one workforce. What does one workforce mean in practical terms? I mean, patient safety is jeopardized by staff working in unfamiliar settings with unfamiliar colleagues. And that's also a major risk of staff feeling so insecure that they leave the service. Close teamwork is essential to both efficiency and safety. So one workforce often has implications of passporting of staff around the wider system to fill in gaps. I mean, that's how we don't want it to happen. It can also be a useful development facility for staff to broaden their experience and their, if that is driven by their requirements. but I'd like to make a plea that passporting of staff must only be undertaken at the request of staff and with proper support during familiarisation in their new working environment. It can't be used as a way of papering over staff shortages. So could you just explain to me what you mean by one workforce?
Want me to come in on that, Councillor Greenwood? So I think we use that term to reflect the fact that the relationship between hospital staff, community staff, social care staff, VCS, people working in the voluntary and community sector are all connected, and that the service depends on those staff working well and working together. The intention is absolutely to not force people who work in one part of West Yorkshire to go and work in a completely different organisation with a completely different team against their will. As you've articulated, Councillor Hutchinson, we know that there are some staff who would like that opportunity, and it might be part of their career development or might be part of their aspirations to work in different places, and we want to support that, and we want to make that easier than it is currently. But this isn't about a kind of a draconian you must work here because we know the pressures are here, and we know those are most significant. I guess what we're trying to do is in the language of one workforce is reflect the fact that all staff are important, and the fact that they need to work together is essential to integrate care.
So how do we guard against it becoming anything other than a developmental tool bridge?
Well, I don't think we've got any plans. We haven't got any plans to move people around the system against the will. If that starts to happen, I'm sure there would be conversations with staff side, there'd be conversations with individuals, but that's just not the plan. We're not, that's not what we're planning to do.
Okay, well, it'll be interesting to see how it plays out. One final question. Commissioning support units have been an important part of the current arrangements. I've not seen any mention of commissioning support units or their next version in the Constitution, or for that matter in any of the other documents that I've seen. So what happens with all the hundreds, if not thousands, of people who currently staff the commissioning support units and make decisions on who gets what, or facilitate decisions on who gets what roles within the wider health organisation?
So those, sorry, Councillor Greenwood. So those contracts will roll over. So there's a bit of longer term developmental work being done by NHS England around the future of commissioning support units in these arrangements. We've got contracts primarily with the North East Commissioning Support Unit, NEX it's called, who provide services to large parts of West Yorkshire. Those contracts will roll over from July into the Integrated Care Board. We're having conversations with NEX, and we're engaging with the work on NHS England about what those arrangements will look like in the future, but they're certainly not stopping in July as a result of these changes.
Okay, thank you.
And we've got Councillor Smage, and we'll give you the last question, and then we'll move on to the next item.
Yeah, it's just really quick. Thank you.
Yeah.
I just wanted to concur with what Councillor Rhodes has said. The phrase final decision with the ICB does not give visibility of decision-making processes, because as we all know, there will be various decisions at various levels in various places, and all of that needs to be visible and open to scrutiny, and we need to be able to see what is happening, because you could argue that by the time it gets to the ICB, it is actually a little bit late to do much about it, anything. So I think the visibility of the decision-making process in all of this is absolutely key. Thank you.
And I think we can use some of the scenarios to describe how that would work. Potentially that might be a good way into that.
Okay, thank you very much for that. Good questions and some really comprehensive answers. So we'll move on to the next item. I think you're all staying for that anyway, aren't you? Ian, are you hanging around, and Stephen as well?
I need to leave at 12, I'm afraid, but I can absolutely stay for the next item.
Right, brilliant. Okay, then, so item 7, West Yorkshire Mental Health, Learning Disability and Autism Collaborative, and we've got Keir presenting the report.
Thanks, Councillor Greenwood. So just so morning everyone. So I said hello once already, but kind of my name's Keir. I'm the Programme Director for Mental Health, Learning Disability and Autism across West Yorkshire. So quick question before we start is, I can either kind of just talk it through, conscious that everybody's been received the pack already, or I can kind of present to you with the slides, depending on what's going to be easier, Councillor Greenwood. Conscious kind of there might be a preference as to whether you're presented to or whether we just have a bit more of a discussion. So whichever you'd prefer.
Well, here's what we do. If you want to just give a brief pre-say of the whole report, and then question, because the members will have read it. So
fine. Okay, I will do that then. Thank you.
Okay, thank you.
Right. So yes, essentially, so what we're trying to do with the report is essentially describe the fact that we have a way of working for mental health, learning disability and autism across West Yorkshire, which is very much in keeping with the stuff that Ian and Stephen have talked about in the way that we want to work as an integrated care system. At the same time, there is a collaboration of 4 NHS mental health trusts that come together to work across the West Yorkshire footprint and support the wider work of the integrated care system. Now, those things are slightly distinct, but also very, very much joined at the hip. And what the report tried to do is describe how the fact that there are some elements whereby the work of the integrated care system and the collaborative are absolutely kind of one and the same thing. And there are some instances whereby there's a slight nuance between the two. So what the report then tried to do is try and describe some of those elements. So what is our expectation about what happens in place? What is our expectation about what happens across the system involving all of our partners, including the voluntary and community sector, local authorities, etc. And what is our expectation then specifically of the mental health, learning disability, autism collaborative when those 4 NHS trusts come together? I'm really, really conscious that within all of this, the focus for the integrated care board, so the ICS, and for the collaborative is about delivering our kind of big objectives for mental health, learning disability and autism. So they're kind of twofold really. So one is, how collectively do we ensure we deliver our ambition to reduce the gap in life expectancy that we have for people with mental health, learning disability and autism against the rest of the population? Because we know that people with severe mental illness, people with a learning disability, people with neurodiversity die younger than the rest of the population. And also within that, how do we deliver the expectations that NHS England places upon our services to deliver the long-term plan? So that is often about increasing access. Can we get access to more people within our population to children and young people's eating disorder services, for example, or into lower level psychological therapies? How do we reduce the number of people with a learning disability in inpatient settings in line with kind of long-term plan trajectories? How do we stop sending people out of West Yorkshire for their care when ideally we want to provide that care for them within West Yorkshire? So all of that stuff is how we are trying to come together. The Mental Health, Learning Disability and Autism Collaborative. So I'm going to try and make sure I pick up here kind of Councillor Rhodes' questions from earlier on. So just to be really, really clear about what the collaborative is. So it is a collaboration of 4 NHS trusts. So Leeds Community Healthcare, Leeds and York Partnerships, Bradford District Care Trust and South West Yorkshire Partnerships. That is the Mental Health, Learning Disability and Autism Collaborative. And it's been in operation since about 2018, when those 4 organisations decided to come together to work together on those issues where it's felt actually we need to do some things at scale, or we need to have conversations between our organisations to support how we learn as individual organisations and share good practice. Very, very much in the same way that WIAT works, for the West Yorkshire Association of Acute Trust, a similar kind of concept really. So that does mean that there is a formal committee structure, which means that once every quarter, the chairs and chief execs of those organisations come together to talk about that joint work plan and to talk about how we share the work of those organisations and where they interact. And twice a year, we also bring the non-exec directors and the governors of those organisations together where they have governors, so recognise at least Community Healthcare aren't a foundation trust, so they don't, to talk about the work plan, understand what it is that the work of working in collaboration is trying to achieve and how we're making progress against it. And then the specific point about mutual aid that was picked up earlier on is basically, how do we ensure that we have strong relationships between the the clinical and the operational leaders of those organisations so they work well together. So our chief operating officers of each of those 4 organisations, particularly the 3 inpatient providers of mental health services, more than Leeds Community Healthcare, come together regularly to talk about what are they experiencing in their services, where are their pressures, what are they doing to try and address those pressures, how can they share ideas between themselves about how they might improve that, what do they do together, what might we want to work on together to kind of crack some of those issues. So the same goes for the medical directors, the same goes for the directors of the nursing, the finance directors, the HR teams, and the operational teams below that. So that kind of concept of mutual aid is basically how are we getting the relationships right between those 4 NHS providers, so that, for example, our work during the pandemic has allowed us to try and share what are our approaches to making sure our infection prevention and control processes within the mental health trust works, and is kind of striking that balance between making sure we are being as COVID secure as we can do, but also increasing and maintaining that capacity that our services have to support people with mental health, learning disability and autism. So that's essentially where the collaborative comes in. And the one thing I really want to draw some attention to was on slide 8. So I will actually talk this through. I know people have kind of got it in the pack, just to try and describe a little bit of kind of how the responsibilities and the difference works between the different organisations. So what we have at the minute is essentially there are certain services which are classed as specialised services within NHS England language. So they're things that historically NHS England would have commissioned on a kind of a larger geographic footprint. NHS England retains accountability for those services, but funding and the responsibility for those services, for 3 of those services, so for adult secure services, so kind of forensic services, for children and young people's inpatient services, what we call kind of tier 4 inpatient services, and for adult eating disorders, is now the responsibility of the provider collaborative. So NHS England has given the money and given the responsibility to our provider collaborative, said it's our job as a provider collaborative to make sure we use that in the best way for our local populations, including reinvesting any money we get back into those services. And what that means is for each of those lines, one of the parts of the collaborative is the lead provider on behalf of the others, but the governance is a collective one. So for example, on adult secure, it's Swift that is a lead provider, but again, the governance is overarching. And for both tier 4 CAMS and for eating disorders, it's Leeds and York Partnership that is the lead provider of those services, but within the overarching governance of the wider provider collaborative. So that's a kind of a line that has been moving forward nationally. It's kind of an NHS England policy decision. We want to move some of those specialised services accountability closer to the places in which they're delivered. Everything else is essentially, I guess you class it as in the non-specialised bracket, and that doesn't mean that they're so non-specialised that they're not the realm of the NHS and kind of clinical services, but they are essentially what we've described as CCG commission services. They're not NHS England commission services. And as we go forward, that all the accountability for those services will rest with the ICB ultimately. That's where the accountability rests. But there are a couple of areas already where what we've essentially agreed with our places is that there should be a pooling of funding at West Yorkshire level, and that the delivery of those services will be through the provider collaborative. So that's the work around assessment and treatment units for people with learning disability, which I know have come to this committee in the past. And it's around work around complex rehabilitation, which is about kind of highly specialised services for a very, very small number of people who often at the minute aren't treated in West Yorkshire. There are over 100 people whose care is so complex that we just don't have the provision for them in West Yorkshire yet. But we are seeking to bring them back into West Yorkshire, both in terms of providing community support and an inpatient facility for those individuals. So the agreement is that funding, rather than going back down to individual places, will sit at a West Yorkshire level, and ultimately the responsibility to be discharged through the provider collaborative in collaboration rather than individual providers. Everything else in terms of kind of funding flows and responsibility goes to the place-based partnerships that I suppose that kind of Stephen and Ian have alluded to earlier and we've talked about with regard to kind of the wider ICS governance. So the component parts of the collaborative, so taking Bradford District Care Trust as an example, sit on their local place-based partnership. So in the Bradford place-based partnership for mental health, learning disability and autism, Bradford District Care Trust are a key partner alongside their local voluntary, local authority, primary care and other partners. So all the funding for all other services flows in that direction through the place-based partnerships. What we then have is a mechanism to try and make sure that we bring together the learning, the understanding, the development conversations about each of those place-based partnerships at a West Yorkshire level with the West Yorkshire Partnership Board. So that's an opportunity to say, actually, how is everyone doing in some of these priorities? How is everyone getting on with the delivery of their long-term plan in their places? How can we support those conversations? How can we stitch together the good practice? How might we decide, actually, there are opportunities here to do some things once again, or to do some things in a couple of areas rather than doing them in each of our places, and to make sure that we are providing that kind of governance, kind of assurance reporting line back up to the Integrated Care Board through the kind of the structures that are coming in on the 1st of July. And then the rest of what the presentation and the pack does is basically try to kind of give some examples, sometimes in words of kind of where the distinction lies, but rather than kind of diagrams between what happens at place, what happens at system, and what happens in the collaborative. And we're really, really conscious that this is not nice and neat, but it is a way that we are trying to navigate the fact that we do have provider collaboratives, and we want in West Yorkshire a provider collaborative, regardless of what NHS England wants, because they've historically kind of NHS England is now moving to a model of pushing provider collaboratives, but we've always thought it's a good thing to have, that our trusts come together and want to work together on certain things and provide that leadership role, and also provide a kind of collective West Yorkshire voice for mental health, learning disability and autism, particularly given the disadvantaged populations and the kind of the issue we face with life expectancy in those groups. But then we are kind of conscious that trying to make things as clear as possible about where the role of the collaborative stops, where the role of kind of the system plays its role, and where the role of place is something we've tried to get through the rest of the report, essentially. But I will stop there because it's a bit of a kind of a summary of what's in it, and more than happy to take questions and reflections from people.
Thank you for that. If I can ask a question.
Yeah.
So if you can walk me through the autism process. I'll tell you why I'm asking that, because in Bradford we're in a mess with autism. It's in a really bad state, and we're talking, it could be 3 years ago now, they had to close the waiting list because I think we had over 300 people waiting on there for a diagnosis. We didn't have either the right people or enough people in Bradford in the care trust to manage that. I mean, I think we gave them something like £300,000 to help them, and they did nothing. It didn't go down anywhere, so they ended up closing the list, and we ended up paying someone in Leeds to do it. They got it down to 0, but nearly 3 years on now, we're back up to 500. It's so bad, I can't begin to tell you. They came to our scrutiny meeting a couple of weeks ago. We absolutely tore strips off them. Now they have promised, they've given us cast iron guarantee that they will get these down. So what difference will it make? Because it's the care trust, as you know, that manage our autism service. But so what difference will this make?
Yeah, okay.
I'm talking, obviously, I'm just talking about Bradford now because that's what I know. But, you know, what difference will that make? How will that help get these waiting lists down?
Yeah, okay. It's a really helpful example. Thank you, Councillor Green. So if you think at the minute, and the way things work is each of our individual places, so kind of historically the CCGs with their local provider like Bradford CCG and the Care Trust still remain responsible for the commissioning and the provision of services for autism and ADHD in their place. And that does mean we have variation across West Yorkshire. So, you know, there is no question that for all elements of neurodiversity, particularly coming out the back of the pandemic, there's more of a challenge now than there has been on waiting lists and on the needs of our population. But even within that, there is variation across West Yorkshire as to how acute that need is, or how divergent the waiting list problem is. And we do know, from conversations about kind of the issues in Bradford. So one of the things that we're trying to look at from a system point of view is how do we, and so what we're terming as our neurodiversity deep dive, how do we understand what is happening in each of our places and what is leading to that difference and that variation? So by understanding what is it about the way that the Bradford patch is set up that means we might have a particular issue, what is it about the way that the Calderdale patch is set up that means that we might have a particular issue, and are there, importantly, some elements of kind of good practice that could be shared? Because actually, if X patch, so taking Bradford and changed what it did a little bit more in line with others, that it might make a dent in the waiting list or the provision of or support that services get. So there's an element of kind of sharing good practice, but there's also an element of trying to standardize potentially as well, because we don't necessarily know at this minute in time, or it's certainly not visible and clear, what the investment profile looks? Is it because actually each different places are investing in a different way? And does that lead into different outcomes? By doing a bit of a deep dive, we can do the compare and contrast and shine the light on that kind of variation, really, and give us an opportunity to have the conversation about, well, what do we do about it from a place point of view? What that also then leads on to, which is the third bit about where the collaborative potentially comes in, is if by understanding the variation, we're able to say, actually, does it still make sense that we have individual providers of care in each of our patches undertaking, autism diagnosis or kind of ADHD diagnosis, given that we know that the resource is finite? There's not, the workforce is always a challenge. The resilience is a real problem, because we're not talking. There are some services whereby actually you've got a relatively large pool of clinical staff or support staff, and when you lose a member of staff, they're able to kind of step in. We know from experience that from an autism and ADHD point of view that we don't have the volume. So is there something about at least ways of working between the collaborative that says, well, what happens if, a bit like the Leeds example, actually, kind of when Leeds did provide some support for it, what happens if we lose our autism specialist in Bradford? How does the collaborative make sure that that gap isn't present, and we can kind of fill that gap collaboratively, either until Bradford is able to appoint, or we work in a different way as a collaborative that means we're not reliant upon a Bradford service, and we can kind of pick up so nobody at this point is clear about what that endpoint may be. So I just want to be really clear about that, because we need to do the work and have the right conversations. And there is something about making sure that each of our West Yorkshire places is in agreement with that approach if we go down that line. But it's worth saying that the fact that we have a collaborative working together puts that option on the table, because we could look at it a little bit more jointly about what the service offer is. I'll stop there now, and I hope that makes some sense.
That's really helpful. We'll be keeping an eye on that. I mean, just so that we've got the care trusts have got 2 people working on this. One of them's coming back on staggered return after long-term sick, and the other one has now got a job elsewhere and will be leaving next week. So we're really struggling massively. So any help we can get, I think, could be very, very helpful. Okay, Councillor Smage.
Yeah, thanks. I think from a scrutiny perspective, we need to look at outcomes, because there isn't. This is structure. The structure is important, but also the outcomes are important for people. And it's how we scrutinise to be able to get a feel that the structure is delivering the outcomes, especially in this area where there are so many delays, that the structure is not preventing the outcomes, but is actually helping to improve the outcomes. And I think that's really important for scrutiny to understand. Now, the collaborative has responsibility for commissioning and provision of some of the services. And I think it is very important that scrutiny can scrutinise the collaborative just as much as it can scrutinise the place, and just as much as it can scrutinise the ICB. And therefore, I think we need to understand how we do that, because the collaboratives do seem to be, they don't have the visibility that the individual trust board decisions have, for instance, and things like this. And therefore, I think it's really, really important that scrutiny can understand the work of the collaborative just as much as the local and the trusts. Thank you.
Okay, Kia.
Yeah, I think it's a fair comment, and I think if you think in reality, we've been kind of building up to the responsibility for collaboratives for kind of a couple of years now, and it was only in October that kind of the go live happened, essentially. So kind of actually the collaboratives formally took on the responsibility from NHS England. But I think the point is well made that, and it's part of the conversation we have about, we don't want the collaborative to feel like it's an entity over there, if that makes sense. We want one of the reasons why, whenever we describe kind of my role in the team that works the team we've got from a West Yorkshire point of view is we're kind of 1 foot with the collaborative, 1 foot with the integrated care board. We're part of the very same entity. So actually kind of the expectations around scrutiny and scrutinising the work of the ICB would absolutely apply to the work that the collaboratives takes on as well. So what we might want to do at some point in time is come back specifically on those areas of collaborative responsibility. So, the ones that have already gone live on eating disorders, on CAMS and on adult secure, to say, this is what it looks like from a kind of a commissioning point of view. This is where our kind of, exactly your point, Councillor Mage, about where are the outcomes, how are we delivering, particularly because we're talking about in some of those areas, how are we going to stop sending children and young people outside of West Yorkshire for their care, for example. That's a huge indicator for us of how we're kind of making progress. Similarly, kind of reduced length of stay, kind of distance from home, those sorts of things. So we can absolutely come back on that specifically at a future point in time.
I've got you down, Councillor Rhodes. I've seen you. Thank you. Councillor Hutchinson.
Thank you, Chair. The long-term plan for the NHS made it very clear that there was a shorter, reduced life expectancy for people with mental health illnesses and learning disability, and felt that there was enormous scope for improving the physical health management of people suffering from mental health or learning disability. There was a lot that could be done to improve that. I can't see anything in your presentation to say how that is actually being addressed. And this is the whole purpose of an integrated care system, is to integrate stuff. But the diagrams and examples, the bite-sized case studies, still show to me that even within mental health services, it remains extremely fragmented. And we've, in the Burnt Bridges report in Calderdale, we commented on the way in which each individual area has its criteria, that it will take on patients, the care of certain patients but not others, and that there's so much scope for people falling between the cracks. I'm not reassured by this presentation. Those cracks seem to be very, very wide and very, very numerous. Am I wrong?
Okay, shall I come in on that, Councillor Greenwood? So you're absolutely right in saying that, when we talk about it as a system as well, kind of the ambition to improve physical health care for our mental health and disability autism population is vital, hence the kind of one of the big ambitions. One thing I haven't done with the presentation, and to some extent this is about pitching everything or versus kind of the specific bit for mental health learning disability and autism in isolation, is we work really, really closely with our colleagues from a West Yorkshire point of view in our improving population health team about the wider prevention agenda and linking together elements of prevention for, so how would we understand the impact of mental health and cardiovascular disease, and trying to support earlier intervention for those groups, for example. There are bits of work through the community mental health transformation piece that is happening in each of our places, but kind of coordinated at West Yorkshire, which is essentially about the triangle of relationships between your community mental health teams from an NHS Trust point of view, primary care and voluntary and community sector teams, about understanding in the community the holistic needs of the individual. And one of the areas there that is a real focus is about trying to ensure that we improve the uptake of physical health checks for people with severe mental illness. And we've got some really, really good practice in our patch that we come back to, that kind of sharing of good practice and the variation piece, but really, really good practice in our patch, particularly for improving physical health checks for people with a learning disability, that through the kind of West Yorkshire work, we're trying to share more widely. And that helps to at least understand and get a better sense of what people's physical needs are. Then there's a tail to that then, which is about how do we respond in knowing that information as a system and as individual organisations. And a really, really good example is some of the work that we've been building on that has been undertaken in Calderdale by the Foundation Trust with regard to people with a learning disability. So by identifying on kind of elective waiting lists, so you kind of your normal 18-week waiting list for hips, knees, kind of other kind of services, by trying to identify people with a learning disability on those waiting lists, to identify where are they on the waiting lists and how might we prioritise treatment for those individuals, because we recognise there's an inequality need compared to other people. If we can do that in Calderdale, how do we share that and do that in other areas of our patch as well? So you're absolutely right to say it's not, I haven't gone enough detail on it in the presentation. It's not necessarily the focus when we're talking at a West Yorkshire level about what the collaborative does, because we're talking about kind of some of the relationship between the mental health trusts, but it is absolutely about the relationships in place and the place-based partnerships, about how they stitch together the conversation about physical health care, mental health care, and learning disability support as well. But there is still plenty more to do, and some of that is about how we really maximise the opportunity we've got with this community mental health transformation piece to get that relationship between primary care, VCS organisations, and the mental health trusts in the same space, essentially. And some of that also links to the opportunities that employment provides. So how do we help get people with severe mental illness into employment through things called the individual placement and support scheme? The more we can do with that, we know that has the knock-on benefit of kind of helping people's physical health care as well. So it's, yeah, by no means is it forgotten about, but it's definitely not. It's not. I've not brought it to fore in the presentation, which is true.
And reducing the number and the breadth of the cracks between the various aspects of the service that you've described.
So, which bit specifically? Sorry.
Well, the whole lot. You know that. There's so many different separate services, each with their eligibility criteria for taking on patients and what they will deal with and what they won't deal with. And, you know, that people do fall between a number of stools and get lost. And what is there anything going on within this integration program to actually integrate things?
Thank you. Okay, yeah, that's really helpful clarification. So if I take a couple of examples, so and it's worth saying is the focus on this is about kind of some of the specific cohort areas, if that makes sense. So for children and young people's mental health, the benefit of having a provider collaborative and the benefit of having kind of a West Yorkshire inpatient service offer provided by Red Kite View, but actually is fed by the 5 places. So kind of what the ideal is, in the ideal world, we don't want anybody, a child or young person, in an inpatient unit if at all possible. But we know that's not realistic, and what we want to do is make sure that's provided if possible. Making sure that the eligibility criteria for anybody coming from Kirklees or Calderdale or Bradford or Leeds or Wakefield who goes into Red Kite View is the same. The process is the same for those young people. The kind of the acceptance of what is needed for them to be admitted to Red Kite View is the same as part of the provider collaborative arrangements. We're having similar conversations about the ways in which things like our psychiatric intensive care units for adults work as well. So at the minute, and historically, those units do work independently. They're part of the fabric of their individual organisational trusts. So the Bradford District Care Trust and its psychiatric intensive care unit, similar for LYPFT, similar for SWIFT. But bringing the clinicians and the operational teams together says, what should the standard operating procedure be for our PICU, so that actually your point around almost criteria and who comes onto a PICU is the same, because they're not at the minute. They are varied, but the opportunity of working in this collaborative way is to get that stitching together and say, how do we bring that together in one way? Go, what's the best way of working that we can get to, so that we aren't having that variation? And it does take time. It takes time to kind of get agreement on some of those things. Some of these kind of working practices are long rooted, and they are the product of the need of individual organisations and places. But by stitching together the right people, particularly from a clinical and operational point of view, on things like the PICU work, getting a kind of common data dashboard that shows what's the impact, what is the impact of actually your working practice being different in Wakefield and being than so in Leeds, and holding that mirror up is a real benefit and opportunity for the collaborative. But yeah, I will stop short. By no means have we cracked that in a whole host of areas, but we're really conscious that is the opportunity that working in collaboration provides, is to understand the variation, say where are the opportunities to actually standardise how we work, so that we don't end up with a difference in kind of expectation or provision for different parts of our West Yorkshire population. That's the aim.
Thank you.
Okay, thank you. So I've got Councillor Marshall, Katung next, and then Councillor Rhodes.
Thank you very much, Chair, and thank you, Kia, for your presentation. My question, of which you have touched on some of the issues, and Councillor Smage also mentioned outcome, which was one of the things I needed to ask. Well, mine is more data, of course, and the outcome. So the examples you have given just now, if we touch on children and young people's mental health, for us to be able to understand the collaborative work in all these different places that you have mentioned, what is the data that has been presented to us for us to be able to even look into the impact analysis in all of these different places? We don't have any of that, and I'm really concerned about, you know, the impact of mental health, especially in the last 2-3 years in children and young people. So I think with all of us having this structure as a board, and for us to go back to do the work that we do in terms of scrutinizing all of this without data and outcome, then we're just reading stuff theoretically.
Okay, thank you. And I think I guess it depends on the conversation. So really importantly, so the element about data is lots of data exists, you know, that NHS England's provides to us as a system that kind of, so an individual providers of mental health services, whether they be voluntary community sector or they be NHS trusts, submit data into a national database that then tells us basically how are we performing, are we delivering against our expectations and our trajectories for the number of children and young people, for example, we want to be seeing with an eating disorder, how are we doing in delivering against our out of area placement trajectories, so sending people out of area or keeping them in West Yorkshire. So that data absolutely does exist. The conversation that we wanted to have today, or the ask was essentially kind of how does the kind of the ICB and the collaborative interface with one another, and what's that going to look like as we go forward? There's absolutely nothing to say that in future discussions we can't get more into kind of the, and what's the data telling us about how that's working, because it does exist. You know, from a kind of a West Yorkshire point of view, we're going through a planning process now with each of our places that basically says this is what the ambition is within the long-term plan for each of our kind of service lines. So it could be IAPT, it could be children and young people's mental health, it could be kind of dementia diagnosis. This is what the ambition is in the long-term plan. This is the investment we know that's coming into mental health. What is the expectation around the numbers of people we're likely to see about NHS England trajectories? And once we've gone through the planning process, we'll have an idea of where we feel confident, or we feel that there's work that needs to be done to make sure we're going to get as close to those trajectories and deliver as possible. It is worth saying, though, that it will be no surprise to most people that there's real pressure on kind of delivering against the expectations of the long-term plan across the country at the minute, and a whole host of areas as a result of the pandemic. So yeah, there is, you know, pressure upon services on a kind of a daily basis to deliver against the trajectories that are already set. But if we want to have a conversation about what that looks like and how we're delivering against that at a future discussion, we absolutely can do. It wasn't a deliberate oversight. It was just kind of trying to take the bit about what's the relationship stuff between the kind of the collaborative place and the ICB at this point in time. So you've got that that kind of context, and we can absolutely delve into the more specifics of the future, if that'd be helpful.
Okay, thank you. And Councillor Rhodes.
Thank you, Chair. I'll be brief. Some of the comments have been mentioned already. Keir, thank you for your presentation. And obviously there are still questions about it that need some answers. First of all, the mental illness service as a whole has been the Cinderella of the NHS for too many years in relation to the funding of it. So at the moment in time now, when I'm looking at your report, we've got the psychiatric intensive care unit and the community mental health. Obviously, Colin has touched on the criteria for projects to go to the ICB board for funding to come back to place to deal with these issues. I'm very concerned that if there is a list of criteria, that there will be inequalities across West Yorkshire in terms of, we'll say, bluntly doling out the money. Secondly, I'm also very concerned when I look at the graph that there seems to be a split in the area of, I'm just going back onto it now. When I look at your graph, how the governance works, in one box, we've got the issues about the mental illness. And then we've got another graph, which is on about psychiatric provision. I mean, surely there's a correlation between the two. You mentioned about the collaborative, and I'm lucky in Wakefield as chair of the committee, that through Sean Rayner, we get briefings to update us on the situation in terms of waiting lists, etc. I have a concern about the funding for future projects to bump up the plans that you have. And at the same time as Vanda and others, is the amount of waiting time for autism to be dealt with in its format. A question, please, Keir, is how do you intend with this collaboration and the process you've identified here to work with the local level in terms of the training? And I will say this in general, the training that's needed at doctor surgeries for somebody who now, through the past 2 years, have not been able to have face-to-face and they're care navigated, as they're calling it. The same training in schools to help teachers support children who have behavioural problems. As we know, some schools are prone to expel children who have problems rather than deal with them as a degree of autism spectrum. And how is that going to help the local situation at ground level? It's very important that any project or any development of plans, I mean, most town halls across West Yorkshire could be papered over and over again with projects and plans that really, as our colleague Abigail has said, we need to see the data that delivers the outcomes. I think it's important that there is that local ground information across West Yorkshire to give assurance that the best is being done and how the funding is being allocated and what terms and criteria, as Colin has identified previously. It's very, very important. And the last one, in terms of the collaborative, you mentioned about one authority like York or somebody else taking a lead on one emphasis or one part of it. Can I ask, in terms of the collaborative and the specialisms that's needed, will the collaborative staff that are needed come to the patient, or will the patient be expected to go to the experience of another authority? Because that is something that really has an impact on a family. And I think the interface is so important that that needs to be ironed out. We are in a position now where we have a lot of children and adults who are desperately in need, as you've mentioned. And one part of this here that has been on an increase, I'm sure you know, is the amount of young people up into their 30s. I think the stats show that it's mainly some people in their 30s have committed suicide. And the suicide prevention in terms of how that's working as a collaborative together with the psychiatric needs of all, that's so important. Self-harming is not mentioned, which is another element in the young people of what's happening out in our districts at the moment. So it's a welcome project, but the last thing about it is this. When you keep saying it's going to take time, everything takes time, I appreciate that. What is the target time then for this to have a full evaluation, Keir?
Thank you, Councillor. Shall I come in, Councillor Greenwood now? So 3 bits, I think. So in terms of the evaluation of the collaborative, the bits that the collaborative is responsible for, if that makes sense. So the kind of the specialised services that have been delegated to the collaborative, that is an ongoing evaluation piece that we do through the collaborative. That is ongoing. I guess kind of the impact that we're having as a system, including kind of the responsibilities of each of our places in delivering the ambitions of the long-term plan, is about, are we meeting those trajectories or not? And there's a very kind of blunt instrument that says, if at the end of the intended time period, we haven't reached the trajectories, for example, for reducing out of area placements as a system compared to what NHS England expects, that we've not delivered what we wanted to do. Now, there may be mitigating reasons for that, but actually we will be clear about whether we've delivered that or not. The really, really helpful point about kind of the collaborative and that worry about, does that essentially mean that, you know, service users from each of our places have to trek across the patch to get that specialist service? I'm going to give just a couple of examples because there's slight variation in how this works, but it kind of, hopefully it'll provide a bit of context. So if we're talking about a service such as adult eating disorders, which is a specialist service provided by Leeds and York Partnership on behalf of West Yorkshire, it's called the Connect service. If inpatient treatment is required for people's eating disorders, they absolutely do need to travel to Leeds. That's where the specialist provision is, and that would be no different than if we expect people need to travel to St James's Hospital for certain amounts of cancer treatment. But what the Connect service also does is it outreaches into each of our 5 places and provides community-based specialist adult eating disorder services into the places as well, to try and keep people out of the inpatient services in as close to their homes as possible. So there's a large number of people on the adult eating disorders services books who are in their own home in the community. They are not in an inpatient setting, so they are getting supported in their community. And at the same time, then there's a lower level of that, which is kind of the more disordered eating support that each of our places should be picking up through the services they're commissioned to provide in each of their individual places. So you can see a bit of a kind of an escalation all the way up to kind of inpatient services, but the intent is to keep people as close to home as possible. And it's not dissimilar from a children and young people's point of view either. So, you know, so if people need admitting from an inpatient point of view, we know at the minute still too many of our young people go outside of West Yorkshire. The development of Red Kite View in Leeds has increased our capacity, which means that actually if people need inpatient support for from a children and young people's point of view, they're more likely now to stay in West Yorkshire than ever before, but they will be in Leeds. But then each of our 5 places does have community children and young people's mental health teams, and their job working with the kind of the specialist centre of Red Kite View to try and make sure that we know who's at risk, where is the potential that a young person might ultimately need admission to the inpatient unit, and to do their joint work to try and make sure that doesn't happen where we possibly can do, and to keep them as close to home as possible. So there's a lot about that interface, and it kind of picks up Councillor Hutchinson's point, I think, about the seams and the interface between community teams and the inpatient teams becoming a consistent and a constant dialogue with a kind of an agreed way of working, so that we do try and make sure that the fewest people as possible need that inpatient care. And then finally, on the money, so from a mental health point of view, there's really clear expectations from NHS England still, which is a really good thing when you're sat in my shoes, which is about increasing mental health investment over and above other investment in health services to try and get close to addressing some of that historic imbalance that you alluded to, Councillor Rhodes. The expectation is therefore that each of our places, in terms of the allocations that they get, continue to over-invest, if that's the right term, in kind of mental health comparatively to kind of other services. Now, that is obviously against the backdrop of a massive efficiency challenge that the whole NHS is being placed under over the next kind of year or so. So it's not quite as neat as to say that that there's kind of a lot of additional investment coming into mental health. It's much, much tighter than that might seem. What is trickier is that, unlike mental health, learning disability and autism doesn't get that same national push. So the conversation we are having to have with partners locally is, how can we work smarter? The collaboration piece we talked about earlier, what can we do collectively? How can we use often non-recurrent funding, which is kind of as Councillor Greenwood's point about sometimes you can break through a waiting list with a bit of kind of non-recurrent funding, but how then do we sustain the fact that kind of we kind of broke through the waiting list? So there's potentially conversations we need to have as a system and in each of our places about relative prioritisation, because it's not like NHS England is giving additional money for kind of for autism or for learning disability per se, certainly not as part of baseline funding. So I hope that helps a little bit with some of those questions, Councillor.
Thank you for that. Councillor Smage.
Yeah, on your diagram, how governance works, you've got your blue and your cream boxes, but in the middle box that's both blue and cream, you've got question marks against ADHD and autism diagnosis. So why have you got the question marks there? And where is the accountability going to be for those diagnostic services? The question marks just feel a bit as if, well, it feels that that's where we are with those services, question marks. So it just doesn't feel as if it's got a place, and it should have a definite place for accountability. Thank you.
I'll pick that up. Yes, thank you. It is deliberate, so it's not kind of so essentially when you think of the reason for that kind of, as you rightly say, the kind of the blue and the cream boxes, what we're trying to say is that there's a bit of a joint responsibility there between the collaborative, the mental health LD and autism collaborative of the 4 NHS trusts and the wider kind of system work. So there's a bit of a role for both, really. When we're talking about things like psychiatric intensive care, we're pretty clear that there is going to be a role for the collaborative in taking on some, as I already talked about, in taking on how do we develop a standard operating procedure? How do we develop a clear data dashboard? How do we develop the clinical network that the collaborative owns that will help that PQ conversation be a bit more consistent? Where we've got to with ADHD and autism at the minute is that we've got to the point where, frankly, we know we probably need to do more in collaboration between our places than we maybe have done in the past, but we're not sold for definite, or we're not clear if actually there's a role for the mental health LD and autism collaborative to own that and to deliver that on behalf of the system, if that makes sense. So what it's trying to essentially say is, when I set out a little bit earlier on that we're doing that neurodiversity deep dive piece, and the point of that neurodiversity deep dive is to go, what is the variation, what is the good practice, what's working well, what's working not, and understand the totality of the picture across West Yorkshire. Once we've done that, the reason why the question marks exist is, one of the questions is, as a result of knowing that, is that something we want the collaborative, the mental health LD and autism collaborative, to take the lead on delivering, or do we think this is something for each of our places to own, with maybe a bit more kind of stitching together? So hopefully that helps a little bit. It's why it's a little bit up in the air, because we're not sold on what the end point will be for that discussion yet. We know that there's more work to be done, but we know that collaborating is a really important part of getting to the right answer. We just don't know if it's going to be the mental health LD and autism collaborative that needs to be the one that holds the ring on it ultimately.
Okay, Councillor Hutchinson.
Thank you, Chair. I just wondered, Keir, if you could tell me what the difference is in practice between accountability and responsibility, because they're both feature on that, how the governance works. So, you know, to me, they're very, very similar in terms of what they mean.
Yeah, okay. I may tie myself up in knots here. Kind of, this is a Stephen Gregg thing. You're probably better at this than me. But essentially, the gist is, if I take the specialised services line, which is probably the easiest one to describe, so the reason why it says NHS England is accountable is that even though NHS England have delegated the funding and the responsibility for the kind of day-to-day operation of those kind of specialised services to the collaborative, ultimately, in kind of legislative terms, it's still NHS England that is ultimately accountable for the quality of those services as they're provided. The same goes for the Integrated Care Board. It's ultimately accountable for the quality of services that are provided, although it's delegated elements of responsibility for the discharging of that to a different entity. That's the kind of the gist, really. So in the same way, I am probably going to say the wrong thing, but in the same way that ultimately the Secretary of State for Health is ultimately accountable for kind of the provision of the National Health Service, but responsibility is passed through to the NHS and to NHS England and to the kind of the Integrated Care Board. It's that kind of language, essentially, which makes a bit of a distinction. But I have to admit, I sometimes do struggle with it myself, because it's a bit kind of, there's not a lot of, you just put a paper through them, basically.
Yeah. I mean, it does make a difference if we're wanting to scrutinise the service, as to know who we need to ask to come and sort of speak to us about it. You know.
Yeah, and I think just on that point, I think the reality, so taking that NHS England, the specialised services example, I think the reality is that NHS England retains accountability for the totality of the specialised services portfolio across the country. So realistically, they're not the ones to talk to about what's going on in West Yorkshire. Because the provider collaborative is for those kind of specialised services elements. So, but yeah, I take your point. I'll go back and check to make sure I'm not using the wrong terminology in the wrong order.
Yeah,
just to be sure.
Thanks. Words are tricky things.
Right, that's great. Nobody else has got their hands up, so thank you so much for that, Keir. That was an interesting item.
Yeah, and please, yeah, like I said, we are either as the collaborative or kind of the wider work that the Integrated Care Board is doing on mental health, LD and autism, more than happy to kind of talk about specific bits of work in the future, the kind of the output they're trying to achieve. Yeah, so thank you for the invite today.
No, that's fine. We might invite you along to Bradford Scrutiny sometime. Yeah. Okay then, so that was the final item, I believe. So I've lost my agenda now, but I think it's the work programme next. Mike?
Just very briefly, Chair, thank you. I'm anticipating that the next formal meeting of this joint scrutiny committee will be after the elections in June, when the 5 councils may appoint different people. In some instances, I'm sure we'll appoint different people because 2 members are leaving. Just to talk, in the pre-meeting, there was some discussion about having an informal seminar to pick up some of the issues before that meeting in June, and I'll talk to Councillor Greenwood and to Ian Holmes about that. 2 outstanding, well, two issues that are around. The Acute Trust Collaborative, WYAT, West Yorkshire Association of Acute Trusts, weren't able to make this date today, but they are willing to come to a future meeting and have a similar discussion to the one that Keir has led this morning. So we can arrange that. I'm also in conversation with Emma Wilson from NHS England about dentistry, which is something that we did say we'd pick up on. And I've suggested to Emma, subject to your agreement, that we also look for perhaps an informal discussion on dentistry in the first instance, so we can get that in before the end of June, which is likely to be when the next formal meeting is. That's all that I've got to say about work programme issues. I would like to say thank you to Vanda Greenwood, Councillor Greenwood in particular, for the work she's done as chair this recently, and for her service on this committee for probably 9 years, I'm guessing. And to Councillor Jim Clark, who isn't present but has told us that he won't be standing for council again in May, because he's been a regular member of this committee for many years. I hope I've not missed anybody, and it maybe would be, but thank you for that.
Yeah, thank you very much for that, Mike. I mean, we might be sneaking another one in. I think you've threatened, haven't you? So I might be back for one last time. Councillor Ramsey, you got your hand up. Did you want to say something?
Just very quick, really. And I suppose it's because I'm new. How do the overview and scrutiny committees in council feed into here so that we know exactly where we want to focus? I thought your point about autism services in Bradford and it being almost a single point of failure was really good. And I thought Abigail's point about having some key performance indicators so we understand where the risks are is good. And I'm not sure that we're going to get a risk register so we can focus. So whilst I understand, Mike, you're identifying things that have obviously been mentioned in the past, I'm just trying to understand what the process is to make sure that we have a good system for looking at all areas around scrutiny.
If I may, I mean that's. I mean, there's always been a bit of a. Members have always been very keen to make sure that things are done locally, where it's appropriate that they're done locally. So we've always tried to work on the basis that if something's a Kirklees issue or a Wakefield issue, that is that those are the, if you like, the important. That's the important place where those discussions should take place. So we have tried to make sure that the issues that we raise here are those that are best done. A bit like Stephen and Ian's 3 tests, that things are best done at a West Yorkshire level rather than a local level. But any of the local committees can feed into this scrutiny board and ask for something to be raised. And I think Bradford did, for example, on dentistry. That's an example where they'd like it picked up on a West Yorkshire level. And any member of the scrutiny board can email or phone me up, and I'll talk to the chair about how we work that through. I don't know. Hope that answers your question.
Yeah, I think it part answers it, but I think the what we know is at the moment that waiting times, waiting lists are rising, that the quality of service is suffering because people are not gaining access when they need to. So we know that across the board, and I suppose what we don't know is where that is having the most impact across the board. And obviously we're talking about a joint system, so it's how that joint system supports if we've got really difficult areas. So but thanks, Mike.
I mean, presumably you're on the your local scrutiny committee, are you?
No, and that might be a problem for me. That might be where I need to talk to somebody.
Because how it normally, I don't know whether it's unofficial or
sure.
official, but we normally have either the chairs or at least a member of each scrutiny committee on here. So because there's a lot of things that don't affect West Yorkshire. You know, there's a lot of things that we do locally.
Well, Liz is, so I'll pick up with Liz.
Yeah. Okay. All right. Fine. Okay. Councillor Marshall-Catung and then Councillor Smage.
Yeah, thank you. Mine is just to say thank you to pulling on what Mike has said in terms of members leaving. Councillor Latty is stepping down from being a councillor in Leeds after over a decade and has been a very invaluable member to the Health Scrutiny Board, and obviously both of us represent Leeds here. So it's just to use this opportunity to say a huge thank you to you, Councillor Latty, for being such a great comrade and member of the Adult Health and Scrutiny Board. So thank you very much. So it's his last meeting, so if we can all be kind to him.
Thank you very much indeed.
We always are, aren't we?
My contribution in Leeds has been much greater than it has been here, which has been quite marginal, but I've enjoyed it. Thank you.
Good. Thank you. Councillor Smage and then Mike.
Yeah, thanks. We'll pick up with Jackie about the local, because we'll Richard and Yolandi we'll pick up with about that. Okay. But I just wanted to second what Mike has said about thanking everybody and yourself, Councillor Greenwood, for being part of the committee, and for those who are retiring this time. Thank you.
Thank you for that. Mike?
Sorry, Chair, I seem to have got some, I've lost them. I had some applause for Councillor Latty that's now disappeared. So
no, we'll all. Okay, well, thank you all, and hopefully I'll see some of you, if not all of you, again. Okay, and I'll speak to you, Mike, about this potential other meeting that you're going to put in. All right, thanks again. See you all later.